You guys can
Back,
find it out who I'm
everybody.
talking to.
This is why are you talking over me, Eddie? We just started the show. Jeez, this is a clunky intro. It's probably because you're in a new room, right? Yeah, that's
All
right.
right, I'll
Keep your
shut
mouth
up and
shut.
let you talk.
We should probably just keep that.
So we're doing CBT, EMDR.
CPR.
CPR, yeah, exactly.
Oh, my eyes are watering. Where'd Kevin go now? He's a little
producing
he's like
role.
the
I hid myself.
second moon of Endor.
He's like the
The
Hal.
two sons of Tatooine.
Please tell me this is the intro for real.
This is the intro. This
3, 2. Welcome, everybody. Thanks for tuning back into the Guns and Mental Health Podcast. I always say tuning. I don't know why. Maybe I'm stuck with terrestrial radio, but thanks for downloading and logging in and listening to our content. We have a big panel today. Not only do we have the 4 clinicians, Brandon, DB, Eddie, and myself, but we also have president and founder Michael Sodini and our marketing guy, Kevin, who's just eavesdropping because he likes to grab sound bites for content purposes. But today we are going to talk about cognitive behavioral therapy. And this is something that gets tossed around quite a bit among not only the clinician circles, but the pop psych and cultural circles as well, because people hear this and they think good things, as they should, because it's a good intervention, good modality. And I thought we were doing CBT. We're doing EMDR. Great.
When I asked earlier, I was
we're doing CPR. We said we're doing CPR today.
Yeah, I was not joking.
Sleepy-R.
All right, take 3.
5, 4, 3. Welcome back, everybody, to Guns and Mental Health. Thanks for downloading and logging in and doing whatever it is you do to access our content. We are always stoked to have you listening and proud to know that people actually want to hear what we have to say. It's really humbling. So without further ado, we have a big crew today, actually. We're going to get started with the show. Brandon, DB, Eddie, and myself are here, of course, but then Michael Sodini, president and founder, is with us also. And then our marketing guy, Kevin Barry. My marketing guy, Kevin Barry, is dropping in so he can listen to the show and pull sound bites. And he's marking times on the recording, I'm sure, to get those where they are without having to rewatch the whole show. But today we're going to talk about EMDR, and I'll let Brandon, who's leading the show, discuss what that acronym means. EMDR is talked about a lot with regard to like trauma recovery and so forth. But we figured it's a good idea for us as clinicians to share with you, the broader public, what some of these terms mean, what the concepts are, how you can apply them in your life. So similar to what we did with the William Glasser show, we're going to keep doing this. We're going to cover different topics, intervention strategies, modalities, and things of the counseling world that don't often make it their way into the public eyeball, or at least if they do, they don't make it accurately. So our job is to try to present the stuff as accurately and clinically sound as possible so that you can know what you're doing when you go into care, or if you don't go into care, you just use the stuff in your own home. So I'm going to kick it around to everybody to say hi and chime in. It's been a couple of weeks since we've seen you all. I was on vacation. You guys were doing other things. But first, I want to hear about DB's trip to rafting. You went on a big rafting trip. I want to hear about that. That sounds really cool.
Yeah, so we had a big kind of ultra marathon canoe race. I think one raft did enter the race, but they did exit the race before the first checkpoint. Maybe 20 miles they might have made it. So yeah, most crafts were from canoes, kayaks, and those sorts of things. And so it was 340 miles was the plan. Also, the plan was for just horribly hot weather, no wind, 100 plus degrees, and just a swelter fest. So we're all planning to be, like pirates, becalmed at sea and somewhere in the Indian Ocean or something. What we ended up with was massive headwinds and rain, just torrential lightning and downpours. And in fact, we got to a point on the race, I was feeling pretty good, actually. I thought, well, this is like paddling in Alaska. Like, it's 80 degrees and wind's blowing in our face. It felt really good. However, the lightning and floods happened in all the tributaries, and they had to figure out some way to call the race. It was never been done in the last 18 years of this particular race, the Missouri River 340. It's never been canceled during the race, and so they had to figure out some way to get 400 boats off of over 100 miles, of spread of the river. And so it was quite an endeavor. The team, the administrative team did a phenomenal job. And so basically they called the race after about 30 something hours. We had another up to 85 hours to finish the race. And we were doing pretty well. My 15-year-old daughter and I, putting in some good times and continuing to put the hammer down. We were 172 miles into the race when we got the text that we had been electronically called at that point. And so that basically, when they called the race, they looked at everybody's satellite trackers and just reconstructed that finish spot. And so quite an endeavor to get everybody off the race. And I suppose maybe the next part is that was about 2,000 miles away from home for us. And so on the drive back, 100 miles from home, we were in a head-on collision. My wife, my daughter, and somebody decided to cross into our lane and right through our lane, and missed me entirely as the driver, and hit my wife's side of the car. So we spent the next 4 days in the ER. I came out with a scratch, and Greta's got 11 broken bones, bruised heart, ribs, or broken ribs, 7 broken ribs, bruised heart, kidneys, lungs, 1 collapsed lung shortly. But man, I gotta say, if I could take just a moment and say, considering all the stuff that just went down for us, any number of those injuries should have killed Greta. Every experience along the way, like from the incident through the hospital care to now, it really couldn't have gotten any better. I mean, the incident was horrible. It sucked. Had to cut the roof off of her to get her off the car to get her out. I mean, it was ugly. But that said, I mean, people just showed up. People showed up immediately with first aid kits, said, I'm an EMT, I'm a firefighter, I'm a nurse. And from the moment I was able to extract myself from the car and provide care, people were right behind me, waiting, or helping. We're so incredibly blessed by the people around us. That's just floored us. I mean, all things considered, this went as well as it possibly could have gone. So I appreciate that, being able to chat a bit about it. And thanks, just if any of those folks are listening, I just greatly appreciate it. People just showed up and helped in an ugly, ugly situation.
What a relief. Really, really glad everything's, coming out the way that it did. That's, that could have been so much worse,
Yeah.
So much worse. Well, thanks for sharing. Anybody else going to chime in there, or do we want to?
I was about to say. So go ahead and top that.
I guess for us, I was so bummed on obviously the incident itself, but for Lucy, she just paddled 172 miles, and she came back to the story of like, well, how is your mom? And for Greta and I mean, of course, like she's doing great, she's doing fantastic. But it's, I know for Greta, I mean, she would be the first to say, I would rather people were congratulating Lucy for that effort, for that solid race that she put in, than saying, how are you, and can I fix you a meal? And so, there've been a solid meal train, people coming by the house and being helpful. But what we really wish we were celebrating is that 172 miles that a 15-year-old put in. And so, yeah, I definitely appreciate the comments around, the Greta's health and well-being. She is getting much better. So yeah, thanks to everybody. And I know this whole crew was really fast to reach out as well. So I suppose it's like so many things. We hear so much of the bad, and there's so much good around us. If we're willing to kind of reach out and be honest with each other, it's where the rubber meets the road, where I think people really actually come together and do the real stuff, the real life stuff.
I'm in the middle of I'm toward the end, actually, of reading the Screw Tape Letters, which I'd never done before. And if you haven't, it's really good. It's C.S. Lewis wrote it, and it's it's actually quite genius. It's a correspondence between we'll call him a fairly high up demon in the construct of hell, writing in response. You never get to see the actual letters from his nephew, but he's writing in response to his nephew, who is one of the newer demons who's assigned to go pull somebody, away from God and toward the devil. And it's really genius. But in reading that, some of the arguments that are made where he's talking about the enemy, but the enemy to the devil is God. So it's like what the enemy will do is he'll allow bad things to happen so that good people can come forward. And I hear that in your story where it's like this horrible thing happened, but instead of focusing on the things you missed, like the cancellation of the race or how challenging it was, or the disappointments or the injuries, it's like, no, look around us and look how fortunate we are to have so much support. And I think that's a real cool shift in perspective. Clinically, we'd call that a reframe. It's a volitional, voluntary decision to look at something through a different lens. One of these days, we'll cover cognitive behavioral therapy and maybe talk more about how we can redirect our thoughts to influence our moods and perceptions. But that's an inside joke for those of you who are listening. But we will do CBT at some point. But I really appreciate the way that you set that up, because I think it's really valuable to be able to know that we are in charge of where we direct our attention and how we can influence our worldview by doing so. Well, Brandon, you want to talk about EMDR?
Yeah, let's do it.
It's our lesson for today.
That's right. So, I appreciate the opportunity to teach you on this today. So, EMDR is a trauma-focused therapy. Being that it's a trauma-focused therapy, I thought it'd be a good idea just to kind of go into, a little intro of what trauma is. And kind of like we did with the Glasser episode, I'll just kind of, walk you through a little bit what trauma is, talk about what some EMDR sessions would look like, and then just kind of open it up for questions and discussion. So, first off, question to ask yourself, what is trauma? I think all of us, kind of can speak to what trauma is and have our own definitions of it. I would define trauma as experiencing something that's beyond your developmental ability to process. So essentially, your brain allows your body to cope with difficult circumstances by managing information. But when you're traumatized, your natural coping mechanisms are on overload and cause a literal block in your brain, essentially meaning you're not able to fully process it. So to kind of, paint a little picture with that, as you go through life, or as we go through life, we gradually go through more intense circumstances that kind of build us up for future circumstances. So the example that I usually give my clients is just imagine the first time that you could consider yourself traumatized. So I give the example of you're 2 years old, you get out of bed, you want to go get your favorite toy, and you realize that your favorite toy's been chewed up by the dog. So, us thinking about that, we think that that's, silly, not that we have toys, but if we had, something chewed up by the dog of ours, it's just more of an annoyance. But if you put yourself in a 2-year-old brain, that's something that can be pretty traumatic. But what you do is, you go through that, you handle that emotion, and that prepares you for other things in life, like getting rejected, getting broken up with, losing relationships, losing friends, all the way up to losing, pets and family members. So kind of where I'm going with that is you're never really able, your brain's not really ready to be, something like physically abused. You're not ever ready to be jumped. You're not ever ready to be sexually assaulted. So things like that, essentially we're just not really prepared for. Those things are kind of off the charts. So what I like to start with, and how I kind of describe trauma as giving what's called in our world is the filing cabinet analogy. So if you imagine your brain as a storage room filled with filing cabinets, you have a filing cabinet for just about everything that you go through in life. So you have one for just your basic motor skills. So like when you know to go to sleep, knowing when you're hungry. You've got one for critical reasoning. You've got one for each of your relationships. Essentially just one for everything. So what happens as we go through the day, our brain processes information, puts it into separate files, and then stores it, accordingly into these filing cabinets. So kind of like I mentioned, those things that you're not ready for, you're never ready. There's not a filing cabinet for, physical abuse. There's not a filing cabinet for sexual abuse, just for examples, because those things aren't supposed to happen. So what happens when you go through those things is you got this big clunky file, of all this trauma with all these papers sticking out, and it just kind of gets shoved into another filing cabinet that it doesn't belong in. And that's a good example of how, stuff from the past can impact your present, like your relationships and things like that. So essentially, EMDR is a great, therapy for people when you have an incident from your past or incidents from your past that's impacting your present. So finally, now that I've kind of gone through, like trauma and a little bit what it does to your brain, I'll kind of go into what is EMDR. So EMDR, it's a trauma therapy. It stands for eye movement, desensitization, and reprocessing. So essentially, it's a trauma therapy that allows your brain to heal itself just like the body heals itself. So for example, like, when you get a cut on your arm, it might take some time. It might leave a scar. It might be a little bit painful in the process, but eventually your body heals itself. EMDR allows your brain to heal itself in a very similar fashion using bilateral stimulation. So when I say bilateral stimulation, most typically that's eye movements, thus eye movement desensitization and reprocessing. So that could be, like a therapist holding a pen, just moving it back and forth and you following it with your eyes. It could be flashing lights that alternate left and right. It could be wearing headphones and having, sounds alternating left and right. And then, what's also popular is they're called theratappers, and they're essentially little plastic nodes that you hold on to that alternate vibrations back and forth. So very interesting concept. I'm sure everybody's probably wondering right now, like, how did this come to be? So there was a psychologist who passed away. Her name was Francine Shapiro, and she was the one that founded EMDR therapy. So what happened with her is she was going through some trauma of her own. And what she would do is one of her coping skills is she would go on walks. And what she would do on these walks is she would look at the rocks in the pavement and just kind of move her eyes back and forth and just to kind of get some visual stimulation as she was walking. So when she got back, she realizes that she was looking at her situation differently. She felt she was able to process it differently and feel a little bit better about it. And she attributed this to the eye movements. So what she did is she incorporated that into her therapy, and thus EMDR was born. And quite literally, it was pretty much an accident. So now that we've kind of gone through that, I'm going to kind of talk about the process of EMDR and what these sessions look like. So I'm going to talk about the phases. So it's an 8-phase process. I'm going to mention each of them right now, and then I'm going to go into each of them. I'm going to go into each of them in more detail. So the first phase is history gathering.
I'm not muted.
You are not.
You're fucking kidding me.
It's okay. I thought somebody was trying to say something. That's why I stopped.
Just start that suction over when I started blowing. I'm on mute. My board isn't clearly being picked up. God bless America. It means my audio sucks too. That means the audio's coming through here. Great. Top to bottom shit in there.
Just give it a couple second break, then go from there.
All right, so EMDR is an 8-phase process. So what I'll do is I'll talk about what each of those phases are, and then just kind of go into more detail on what they look like. So we've got history gathering, safety planning, assessment, desensitization, which is the big part of it, installation, body scan, closure, and reevaluation. So what I'm going to do is I'm going to walk through literally what, a series of EMDR sessions would look like, given the example of somebody getting jumped by a group of people. This is like a fairly easy example that I can give to explain this. So essentially with history gathering, what we're doing is we're finding out, what happened, where are you at, where do you want to be, and what strengths do you have that can help you get there. So using that analogy to kind of fill in those blanks, what happened is you got jumped by a large group of people. Where you're at right now, kind of the measure is you can't go out in public without having a panic attack, or maybe you can't go out in public by yourself. Where do you want to be? Obviously I want to be able to go out in public by myself, and I want to be able to go out in public without having a panic attack. And then from there, a big part of it is identifying strengths. We want to identify internal strengths and external strengths. So examples of internal strengths would be, like determination, motivation, resilience, all things that, one would have if they were, going through EMDR therapy. External strengths, meaning, a supportive spouse, a good support network of family and friends, things like that. So once we get history gathering, that's usually the first session, or it can be a first couple sessions, depending on, how much there is to unpack. We go into safety planning. So with safety planning, the second phase, we're going over risks, coping skills, and essentially just kind of helping people get ready for EMDR therapy, because it can be, since it's trauma therapy, it can be pretty intense. So typically in the safety planning phase, I usually start by giving a bodybuilding analogy. If you can't tell by now, I'm pretty big on analogies. But when you're bodybuilding, what you're doing is you're lifting weights, your muscles are tearing, and then as those muscles tear, they repair and then they get larger. That's very much what you're doing with EMDR therapy. It's possible to take some steps back before you go forward. It does involve tearing yourself down a little bit because you're going through these traumatic memories. But eventually the goal is that you're going to come out of it stronger after everything's reprocessed. It's really important to go over healthy coping skills. So those could be things like, taking walks, listening to music, just any coping skills that you have. And then there are also two coping skills in particular that we teach in there are two coping skills that we teach in EMDR. I won't go into those too in detail right now. If you want to ask me later, I'd be more than happy to. But one's called a safe place and the other's called the container. And the reason we go over those is because we like to end each EMDR session with some sort of coping skill, because like I mentioned, it's really, impactful. It can be really intense. And we don't want to just send people out back into the community after, unpacking all this stuff. We want to make sure that they're calm and that they have, some coping skills that they can, use should they, have some setbacks through the week when they're not, in the office. So after safety planning, your next phase is assessment. So usually phase 3 and 4 are done in the same session. So assessment is where we really start to, identify what we're going to be working on, and we get some measures. So what we're going to do, and again, I'll fill these blanks in a minute here, is we're going to identify the worst part of whatever that target memory is or whatever that target trauma is. We're going to identify a negative cognition that goes along with it, a desired positive cognition that we want to believe. We'll get a couple of measurements, which I'll go into in a little bit. And then we want to find out what feeling does that generate in your body, and where do you feel it in your body? So kind of going back through those. So let's say, for example, with the analogy of, getting jumped by a group of people, identify the worst part of that memory. Maybe that's, the look on this person's face as I was almost losing consciousness. There's going to be, anytime you have one of those like memories, there's going to be a negative cognition that comes along with that, whether it's conscious or not. Once we establish that, we turn it into some sort of an I statement. So a negative cognition for that would be maybe I'm not safe, I'm going to die, something like that. So from there, we identify what's a desired positive cognition that you want to believe. Maybe that's I'm safe, I'm in control. And then we go into measuring these things, because we want to measure, again, with therapy, we always want to identify and measure where are we at and where do we want to be to show progress. So the first unit of measurement, it's called the VOC, which stands for validity of cognition. So we want to find out how true is that positive cognition of I'm safe and I'm in control on a scale of 1 to 7. 1 is not true at all. 7 is completely true. Once we establish that, we want to identify how disturbing is that memory on a scale of 0 to 10. 0 is not disturbing at all. 10 is, absolutely unbearable. And the only reason those are different, like the 1 to 7 and the 0 to 10, and the 1, being a higher number, the 1 being a lower number that you want to get to, it's just so you don't get those confused. And that's pretty much as easy as that is, just so they don't get confused. Finally, what is the feeling that this generates in your body, and where do you feel it? So I'd say in this example, it would probably be fear. And maybe you're feeling that in your stomach and your spine. Because, when we feel emotions, we feel them in different parts of our body. So we want to make sure we identify that. So after we get all that, we get into desensitization. And this is where, this is probably the most complex point of this. And that's where, the bilateral stimulation begins, that I talked about a little bit earlier. So what this would look like is after we completed, phase 3 and filled in all those blanks, I would, invite the patient to, pair everything together. So what I want you to do right now is take that worst memory of that person's look on their face when you almost lost consciousness, tie that in with that negative cognition of I'm not safe, and tie that in with that feeling of fear that you have in your body. I want you to take all those together and just go with that. And once I say go with that, that's when we would start the bilateral stimulation. And we would go through that I would just be silent as we're going through that, and I would just allow them time to process for about 30 seconds or so. And after, we'll stop, and then I'll invite them to take a deep breath and ask, some sort of open-ended question to invite free association. So, what came up? What are you noticing right now? What are you feeling right now? And essentially just let them do the talking. And by doing this bilateral simulation, essentially what you're doing is you're opening your brain up, kind of like an REM cycle. You're fully awake, you're fully present, but with these eye movements, you're just opening up your brain to, come up with these different things so you can process them. So it can go in a lot of different directions. But essentially, after the person, kind of gets out what they want to say and what came up, we say, okay, just go with that. And then we go another set of bilateral simulation. So we do that. And then occasionally what we do is we want to check in on where that SUDS, that subjective unit of disturbance, is at. Because the whole point of desensitization is to get that as close to a 0 as possible, preferably a 0. So after a few times, I'll ask, go back to that target memory that we started with and tell me right now, how disturbing is that to you on a scale of 0 to 10? Again, 0 is not at all, 10 is absolutely unbearable. And if they give me any number other than a 0, I'll ask, okay, what is it that's holding you back from a 0? And once they tell me, I'll say, okay, just go with that. And then we keep on going all the way until we get down to a 0, or as close to a 0 as possible. This can take several sessions. So this is very rarely done in one session. But once we do get that down to a 0 as close as possible, we move on to stage 5, which is installation. Installation is where we instill that positive cognition. So once we get that SUDS down to a 0, I'll ask, okay, so you identified a positive cognition of I'm safe or I'm in control. As of right now, how true do you feel that is on a scale of 1 to 7? And again, 1 is completely false, 7 is completely true. If it's anything other than a 7, we ask, what is it that's keeping you from a 7? And then again, from there, we go through with the bilateral simulation and just allow them to reprocess and just keep inviting that free association. I have noticed that as the SUDS goes down, the VOC comes up, because that's really where a lot of the progress comes from. So once we get the VOC to a 7, or as close to a 7 as possible, we do the opposite of what we did for the desensitization stage, and we have them take that worst part of that memory, and this time we have them pair it with that positive cognition. So literally we are reprocessing this memory. We're taking that target memory, and instead of, I'm in danger or I'm going to die, we're pairing that with I'm safe now. So again, literally kind of like that filing folder analogy, we're reprocessing it. So after that, we move on to the body scan. And that's where, we ask them, I'll ask, okay, so what are you feeling in your body right now? And I will say most times I actually get I have a lot of people laughing at this point. And they'll say something like, I actually feel great right now. I feel like a weight's been lifted off my shoulders. But what we're doing, again, for the example that I gave, is we're trying to target that feeling of fear in the stomach that was associated with that negative memory. So I'll say, now that you have that positive belief installed, what are you noticing in your body? If it's a clear body scan, like the example I mentioned, we just go through with the bilateral simulation a couple rounds just to strengthen that. And if not, we just go through until they have a clear body scan. And then from there, we have closure. Closure is pretty much just what it sounds like. It's, okay, how are you feeling right now? How was this process for you? Do you feel safe, leaving? We review the safety plans that we went over in phase 2. And then, like I mentioned, we'll always end with some sort of meditation just to make sure they're okay to go back out in the community. Phase 8 is reevaluation, which is just ongoing assessments. So, once we're completed with the EMDR process, you start each consecutive session with, how things been going for you since you've completed this process, and just kind of go from there. So with that, I feel like now everybody has kind of like a general introduction to, what trauma is. And that is essentially what an EMDR series of EMDR sessions look like. I know it's really hard not to visualize that. It's kind of hard to take it all in verbally. But with that, I'll go ahead and I'll open it up for questions or discussion.
Brandon, my first question is with the bilateral movement, as you're going through this process, is there always tapping going on, or how does that work? When does the movement and the tapping and the bilateral integration occur? Is it periodically, or is it throughout the whole thing, or what? Because I know there's like lights and stuff, and
Yeah.
I'm getting a little ahead of myself. I'm taking a training actually next year to do EMDR basic, but I'm just curious, like what to expect because I see these things all over the place and I don't know what it is.
Yeah, definitely. That's a good question. So it's periodically, it doesn't happen the whole time. So it's introduced in, well, first off in phase two, where we do the safety planning. That's where we identify what type of bilateral stimulation that you would like to do. So whether that's the flashing lights, the tapping, the eye movements, that's where we establish that. It's actually then first you're doing it in phase four, which is the desensitization phase. So essentially what happens is we'll have them pair everything together. And then I'll say, once we pair everything together, like that target memory, the feeling in the body, the negative cognition, I'll say, go with that. So then we start the bilateral stimulation. That'll go for, about 30 passes or about 30 seconds. And then we stop. And then I'll have them take a deep breath and say, what came up? And then as they're telling me what came up, we're not doing any of the bilateral stimulation. We're just talking. And, as counselors, just kind of reflecting and, just kind of doing the basic counseling skills. And then, once we're ready to proceed, we'll say, okay, so go with that. And then they do another round. So essentially it's several rounds of it, but it's only essentially when it's happening, everybody is silent.
Just for the audience to understand bilateral, you're talking brain hemispheres, right? Right, left, sides of body and
Correct.
brain, because what ends up happening is you start getting into tracks and it's hard to break that track. So you're trying to cross over both hemispheres of the brain and both sides of the body so that the information integrates better. Is that my understanding?
Exactly. And, I mentioned at one point, it's like similar to, an REM cycle. So what I've noticed, and I've actually noticed it on myself, because like when we were experimenting with the TheraTappers, the things that vibrate, when you turn those on and close your eyes, you can't help but move your eyes back and forth. And typically whatever stimulation you're doing when your eyes are closed, your eyes are naturally moving back and forth. And I've noticed, because I'll usually invite people to close their eyes, and when they're doing that, I'll actually kind of see their eyes moving with their eyes closed.
Is this something a client or patient approaches you that they're interested in doing, or are you bringing this to a table as something they could possibly benefit from after intake?
That's a very good question. A little bit of both. So I'd say actually it's about 50-50. A lot of people will reach out to our agency and ask, is there anybody in your practice that does EMDR therapy or that's certified to do EMDR therapy, because they've gone through some sort of traumatic event that's impacting their present. Other times we'll be going through a treatment plan, because essentially when we get a new client for the first time, the first session's like, an intake assessment where we just kind of get some background. After that, we do a treatment plan. And, if there's a lot of trauma, that's usually something that I mention, in the treatment plan as an option. So, it's not the only option for trauma, but that is, if it's something, again, like it's impacting their present a lot from the past, it's something that I recommend that they do. So very good question, but it's about 50-50.
Oh, sorry. Brandon, I've heard that EMDR can be used for phobias too. Is that true? Or is it any negative association? Like how broad of an application do we have for this?
Yeah, it can be used in phobias to an extent. It could be used for substance abuse, depression, anxiety, pretty much a pretty wide gamut of things. But yeah, so let's say, like for a phobia, like let's say if it was like a germ phobia, we can use a target memory, because, EMDR is all about finding a target memory that's impacting them. So we can find a memory where, like they really felt impacted by, this germ situation. And then we can really just kind of go through and desensitize them from that.
So I know generally in therapies, like everything has its benefits and it's like, I wouldn't say negatives, but like where its shortcomings. What are some of the shortcomings of EMDR? Like it's obviously not a magic wand. Like what would you pair this with as a clinician?
Sure. So, so there are some drawbacks to it. I'd say the one is that it was pretty much found by accident. There's really no, from the research that I've, looked at, there's really nothing that shows any like scientific proof of why it works. It's all pretty much in theory. So I'd say, that's one, like potential drawback of it. Kind of like I mentioned too, in like phase two, there are some potentials to where you can actually go backwards a little bit. There was an instance where I was doing EMDR with someone, and we got through it and everything was fine, but we were starting with a memory of physical abuse, and then as we were doing it, it opened up an instance of sexual abuse from somebody completely unrelated. So it can set you back a little bit, if there's a lot of complex trauma. And then I'd say the other one too is that like it's really only beneficial if you've ever experienced some sort of traumatic incident, because like I mentioned before, it's all about target memories. So there's got to be like some sort of memory that you can attribute back to in order to get through it.
And I'll say this because what Brand just described is like sometimes you backslide. You, as therapists, we run into this sometimes when we're dealing with people who have complex traumas. If you're going through something, generally it's bringing out lots of negative emotions. And if you approach your therapist to try to get help, it is natural to have like negative thoughts that are cascading forward, or like in teenagers and adolescents, which mostly what I deal with, you'll see behaviors start to escalate in certain times before we get better. It's not that's not something to be afraid of. Like, oh my god, like my teenager's now not doing well because of this. No, this is exactly how it's supposed to happen. We are moving forward past this trauma. They are addressing it, and their body is, in a sense, freaking out. This is how we grow, and this is how we move forward. And so, what he said, and that the reason I asked that question is, one, I was curious, and two, like that's the natural state of things. You have to kind of go through the thick of it to get better, in a sense.
Yeah, I see Kevin and DB have their hands up, and I want to get to you guys, but I really want to hammer this point. At every intake and consent form, all your consent forms, when you consent to treatment, because ostensibly you're coming in saying, hey, I want to hire you to help me, and you're consenting to the process. We don't want you going in blind and being surprised. Every form should have a disclaimer on there that says something to the effect of, therapy doesn't just make you better. It's sometimes you have to get worse before you get better because you're unpacking a lot of stuff that you've buried for a long time. So that is a warning we have going through. But the promise is stick with us. It does help. Kevin.
What is the process to be able to do this? Jake, you mentioned that you're about to take basic. Is it like a 1, 2, 3 part training, or what does that look like?
Brandon, you could take that one.
Oh, sure. Okay. So essentially, there's two different ways that you can go about it. The way that you go about it that I did just to be able to use it in practice is you need to go through a 6-hour training course, and then I can't remember the amount of hours and supervision off the top of my head, but I want to say it's 25 if I'm not mistaken. But you need to have 25 documented hours of you actually practicing it and using it in session. There needs to be 8 hours of supervision where you actually have supervision going over specifically EMDR, and that's separate to just the supervision that a lot of non-independent counselors need. And then finally, the final hour of supervision needs to be with somebody that is able to certify you in the process of EMDR. So with that, the next step for me, if I wanted to, is I could take another set of courses, which I believe they're 5 separate courses, and I think I would actually have to go through EMDR myself. But essentially, by doing that, I would be able to teach it to people and be able to help them get certified. So with what I went through, just as far as doing the experience, documenting the hours, and getting the supervision, I'm able to say that I'm certified in EMDR and I can practice it.
Yeah, mine coming up is going to be a 5-day long session. So it's like a Sunday, a Saturday, Sunday, Saturday, Sunday, something like that. And then there's 5 separate 2-hour consultations throughout that, as well as another follow up after the 5 are done. So we're going to complete that sometime between February and June of next year, and we're going to get most of, if not all of the Zephyr staff basic trained. And then there's an advanced training also beyond that. I think it's going to be well worth it, quite honestly. The way that Brandon's laying it out and what I've studied about it, it's going to be really cool. DB?
Yeah, I appreciate that. I mean, so many clinicians are being sought out specifically for EMDR. So I haven't been trained in that. I would just echo that solid demand for it. I haven't been able to practice in other areas, but I would know that it's highly, highly in demand. And back to Kevin's question, is this something that people seek out? I would say yes, very much so. It's a kind of a first round question for many, many clinicians. or that many clinicians get. And I also wanted to circle back to something Brandon said about behavior escalating before you move on to the thing, and that really connects solidly to the behavior theory. So it's not just an EMDR principle. This connects to broad psychological theory in the behavior side of things, that what we might call extinction burst. So in order to learn a new behavior, and especially to extinguish an old behavior, if you think of this from a very basic standpoint, which I get is oversimplifying this, but if you imagine the pigeon kind of poking at a button to recognize that this button does something, and so we're kind of classical, learning or operant learning, depending on what you're actually working toward. The idea of how do you teach that pigeon that button no longer does the thing that it used to do. Over time, because the pigeon may have learned that behavior, there's still this sense that it probably would work, that it'll eventually work. And so we do this all the time in our own behaviors, that if we ask mom over and over, we just pester her enough, eventually she'll give in. And that's a really powerful and hard to extinguish behavior. And it requires that mom really steps up her game, that no, that never works. I will not fall into whatever that particular trap is. Because if if she does give into it, or dad, doesn't matter who, but the point is, if mom gives into that behavior, then we're once again reinforcing that behavior does work eventually. So that even as mom is really attempting that in the home with a frustrating behavior with a kiddo, there'll be what we might call this extinction burst, this like ramped up effort to really push the envelope to prove that this will work. And if the parent gives into that, just using a parent example, if the parent gives into that, then we have reinforced that the behavior does in fact work, when we want to teach that it does not work. And so this connects broadly to counseling and psychological theory on so many levels. EMDR is, or can be, labeled as kind of like this other thing, and it's like, well, there's tapping. I'm not really sure what to think about it. But it's very connected scientifically to a broad chunk of research.
Yeah, it looks like there's a lot of, because I was just looking up, because this is the first time I've ever heard of it, but then again, I'm not a clinician, right? We all know why I'm here. I'm the regular guy. But it's really interesting because this is a therapy, from my limited research here, from Google, that I guess they're using it a lot for mass shooting survivors. It's like a default go-to. I'm shocked at how many articles there are talking about people that have survived these horrific incidents, that they have just said that this has changed their life. So it's interesting.
Yeah, and I
Brandon,
mean,
I want to ask you something too. Oh, sorry. Go ahead, finish that, and then I'll ask my question.
no, I was just gonna say that, just to circle back on what Mike said. Yeah, I mean, like, because going through that, obviously, there's a lot of different, symptoms that, because I mean, that's definitely traumatic. So there's a lot of different symptoms that people can go through, and maybe it's they're having nightmares, maybe they're super hyper vigilant, maybe they're dissociating. A lot of different things can come along with that, but yeah, EMDR can definitely help with a lot of those symptoms.
My question is, and I heard about this several years ago, is I know a gal who has been, she and her mentor have been called to natural disasters, and they can actually perform EMDR in large groups, like a couple hundred people. Have you heard of that, or have you participated in it?
I have not.
I may have to get her on. She's gonna end up being our trainer. Kelly Smith Dent is her name, and I might have her talk about that because apparently you can do this in an auditorium. And you got everybody paying attention, right? It's not going to work for everybody, but you got to pay attention. But apparently there's floods and earthquakes and devastation, natural disasters. You get the people together, and you can ameliorate a lot of those negative effects in a group setting. So I mean, it seems to hold a lot of promise for a lot of application that doesn't involve heavy sit down individual psychotherapy. So I just want to throw that out there and see if anybody knew about them.
I did. That sounds awesome, though.
Yeah, and I think, I really want to dive into the behavioral stuff, but I kind of don't because that's a topic for another day. So we'll cue that up. And I'd like to invite a friend on too. She's a board certified behavioral analyst. She's also got her PhD, and she's way, way, way into the strict behaviorism end of things, and she makes a really good therapist. It's not just you put somebody in a box and put them in front of a lever, but the application to that, the behavioral reinforcement stuff that DB alluded to, has application to like interpersonal conflict, especially people with personality disorders. If you're trying to leave one of those people with a raging personality disorder, every time you respond to the behavior, you're enforcing that behavior, right? So if they throw a tantrum to get you to stay and you're in an abusive relationship and you stay, you've just moved that extinction burst up. So it's going to take more effort, or more consistency to leave. And just to put a cherry on top of that, one of the most powerful ways we have of enforcing behavior is called intermittent reinforcement, which is what gambling is built off of, and also social media, because you might post something on social media and it gets a zillion likes, and the next time you post it doesn't, and you'll always be chasing that first post. So it's a way to create addiction as well.
It's kind of funny that you're talking about the addiction stuff, because I host a group with adolescent teens at near one of my near me. There's a group home that I go to every week, and we're actually just talking about the links between ADHD and addictions, and how I know that like EMDR therapy actually is really good for people with ADHD, because it kind of connects the stuff that our brains don't really have firing.
So one of the articles that I came across while I was looking this up was talking about a 10-year-old from Uvalde who it's just obviously has changed her life. What is the age, like, Brendan, like how young have you seen someone come through this type of program, or is there any information on that? Like how young can you send your kid, how young is your kid when you can send them through something like this and be effective?
Yeah, I know it is something that can be done for children. The youngest that I have done it on someone was 8 years old. So what I do is kind of like the way I look at it is, obviously I'll get to know a client pretty well before doing this type of therapy. So instead of looking at age, I just think of something, is this something that I feel like they can, process at this point? So, like if I had to put like an age on it, I'd say like, somebody that's like, like 5 or 6, it would be way too much for them and it'd be very confusing. They probably wouldn't really understand it.
Yeah, that's
But
exactly what I was thinking, because I'm almost like 10 seems like maybe not even,
right.
But
Yeah. And a lot of times too, this is like really interesting, is that like, when people go through, complex trauma and stuff like that, they tend to act more mature just because like they're subjected to like these more, adult things, at a young age. So like this 8-year-old, for example, like I said, like I have a lot of 8-year-old clients that I would not do this with. That have gone through some trauma, but this one in mind that I did do it with, he had a very, very mature mindset, and that's why I chose to do it with him. But that's a really good question.
we nail it, folks.
Is there something we wanted to bring up with application of the gun community? More specifically, we can roll through an anecdote.
I was
Or
thinking that.
vignette.
What about like it definitely applies to like if you use your firearm in a self defense setting, most people do find that highly traumatic.
Yeah, absolutely.
Maybe don't record this part, but I could tee it up. Is this something you can do on yourself afterward? And maybe I'll just rephrase it if you want me to rephrase that.
So, like, if I were to have to use my gun in self defense, would I be able to do EMDR myself?
You cut out there, Jake.
Yes, that's what I'm asking.
I don't know for sure. I don't think so, but I don't know for sure. That's a good question that no one's ever asked me.
Maybe the better question is, can you? I'll just start. So we'll just delete all that and then start from here. Do you think you could do EMDR on yourself, or could you train somebody who's come through your clinic that you've treated into success? Do they then have the skill set later if they experience another trauma? Say they get stung by a bee or something, then they find themselves having an irrational aversion to bees. Can they apply the same skills, or is this like you have to have somebody guiding you through it?
I would say yes and no. I would say yes, you can, but it's not something that I would recommend personally. Um, the reason being is just because, like, in some of the instances I've seen where, like some of those risks that we talk about in phase 2 really do come to fruition. I would want those people to be in some sort of a controlled environment with somebody that's trained to be able to help them with that. But I'd say, like, in theory, yes, you could use, some of these same skills on yourself, but it's not something that I would recommend.
I guess the reason I ask is because when you learn something like analytic psychology and you learn you learn how to dive into your own unconscious and you learn to make peace with some of the things in your shadow, whether they're good or bad. That process can be self-guided. It doesn't necessarily require somebody asking you a series of questions, but I don't know. Can you guide your way through overcoming trauma with this technique? And maybe the answer is maybe.
You have a question,
Danny, what
Eddie?
you got?
So, well, how long is this process? Like, I know, like therapy, we can't ever put a stamp on. Hey, it's just going to take 3 months, 2 months, whatever. But in general, like when someone comes in for like my services, I generally look at like a 15-week service, and with the options, upping them up if we're unpacking stuff still. But generally, how longer of a process are you looking at if someone comes in with some type of simple or complex trauma they're working through?
I'd say, like for each target memory, I would say, 3 to 5 sessions total. But there are different memory. There could be, like you said, mentioned complex trauma. There could be, a series of different memories that have come up that they want to process. So we would do, take it one memory at a time. But I would say for each memory that we're targeting, I would say it takes about 3 to 5 sessions. And some people will say that to do them in like 90-minute sessions. That's not something that I've done just because, like, with our agency, we just have to do hour-long sessions. But yeah, I'd say from my personal experience, it's been about 3 to 5 sessions, with desensitization phase 4 taking usually the most.
Along those lines, is there any regression with that to where you might have to go back to a memory you thought that you kind of treated or got past?
Yes, that's definitely a possibility. And that was kind of like an example of where, the client that I was talking about, that, we were targeting a physical abuse thing. And then just like while talking, it opened up, another memory of sexual abuse. So that's something that, we kind of had to table and then come back to later. And that is a risk where you can, go backwards a little bit. Absolutely.
So, like, you take someone like this kid from Uvalde who's 10 years old that this helped with, and like that is probably the incident. That is the incident that really is affecting their life. But then you take someone like Eddie, who was an EMT, and Eddie's talked about this when he was on the Guns and Mental Health podcast that Jake and I did with his episode, of all the trauma and all the stuff that came from that. Or just take like a police officer or somebody, a vet, right? Like DB, you said this is in the veteran community. How do you say like the target memory, right? Like somebody could have like a million different things that could be the source of this, especially when you're looking at like the whole picture, right? Someone who's been in Afghanistan for 2 years. How do you kind of pinpoint that, or how do we know we're on the right memory? Like it seems like
Yeah, no, absolutely. That's a great question. So a lot of times what I do in phase 1, which is the history taking, is I do what's called a trauma timeline. And that's just a trauma therapy intervention that, we do from time to time. But it's quite literally exactly what it sounds like. You get a piece of paper, make a timeline, start from birth, go up all the way to present. And you just kind of go through, what are all the, traumatic things that have come up in your life consecutively. And then once we have that out on paper, it's usually good to say, okay, which of these do you feel like hold the most weight? What's one that you want to start with? Are there any of these that can be integrated? But that's a really, really good question, and it actually brings me into there's a couple other forms of EMDR that you can do. And the one that you're talking about, or the one that I'm thinking about right now, it stands for the same thing, but it's EMD lowercase r. So essentially, what's happening is when you are targeting a memory and somebody is going, in a lot of different directions, what you do is you kind of bring them back to the one memory that you're focusing on. And essentially, so it's like you're just really focusing on that one memory at a time, if that makes sense. So, really good question, but essentially that's kind of up to the client. And there might be several that we have to go through, and then we just kind of, go through those as, time progresses.
Yeah, I just want to jump in on that point of the trauma timeline. There's so much involved in that, and particularly if a person is then looking at this has taken years, right? This has been an experience over years. I mean, Michael's example of 2 years in Afghanistan, like where do you start? And so that trauma timeline can look at event, follow up to that event, and if you're putting these across several years. What also comes out in that is well, this is a relationship blow up that happened at this time. This was substance use that ramped up at this time. And these things are occurring kind of in the eddy of these traumas, and it may not be caused by them directly, but they swim with this thing. So it becomes part and parcel to these different traumas. They become additive. They become potentially kind of an exponential growth of things over time. And so being able to look at this event occurred here, this event occurred here, and if we can see that on paper, especially for guys and gals who tend to be a bit more prone to not be into the touchy-feely dynamic of therapy, but they can look at, okay, well, these things happened. And after that, these things happened. I made these choices. It's a really interesting and physical way to look at life. And maybe in fact, these are connected. It becomes, in my experience working with first responders, Leos, and healthcare folks, that has been a pivotal piece of recognizing that the trauma actually means something. It had an impact.
Yeah, and I don't know if you've experienced this in doing it, but one thing I've noticed that is it normalizes a lot of the symptoms that they're going through. Because a lot of times, like just our patients, they'll be thinking like, okay, like I'm dissociating, I'm, really quick to aggression, I'm crazy, there's something wrong with me. And when they see this out on paper, it's a great opportunity to say, okay, like there's nothing wrong with you. You're going through very normal things from a series of abnormal events.
Speaking firsthand, I never actually did the trauma timeline when I was getting help myself. I have kind of done a mental look at it myself on this, but while there's lots of bad calls and lots of negative experiences that I could point to different things. I know for myself, there was one major catalyst event that after that event happened, it was a spiral downhill. Then everything started cascading because of choices I made. And I'm not saying someone who spent 2 years in Afghanistan maybe have that, but generally there is one major catalyst that happens and everything else then spirals around that. That's at least the stuff that I've seen. Again, someone can be different. That could be the whole buildup while you're in this one time period was bad. But like, again, for myself personally and stuff, other people I've helped, there's generally one major catalyst that's happened, then the other things spiral around it that they can identify what's going wrong. For myself, it was one major, very horrific bad call, and then the other calls that surrounded that area, I kept getting sucked back into that nightmare.
Not done EMDR. I've certainly not performed it. I've never gone through it. And I could see how the listening audience would be like, I don't want to go to therapy. I'm going to go through literally every memory I've ever had. And it's like, well, a lot of life can be really rough. But for me, and I don't know, I'm going to bounce this off you, Brandon, to see if it's useful. I use this backpack analogy. I'm a big metaphor guy. Also, I use metaphors and analogies all the time because it helps to make things a little more understandable and concretized. When I say backpack, it's like people come in carrying a backpack full of crap, right? And I analogize it to rocks in the backpack. They might be large, they might be small, and we can open up that backpack and pull out every rock and examine it. But some of those rocks are pretty heavy, and some of them are pretty small, and there's a lot of them, right? So I just say, hey, look, take off the backpack, set it down, and if there's some dust in there you find useful that you want to carry with you, that's fine too. But eventually we get to the point where we say, I don't think we need to go through every grain of sand as the rocks have rubbed together in your backpack. Just takes too long. Is that something useful for, say, we'll just say, tour in Afghanistan? It's like, do we have to go through every incident of the 6 or 9 or 14 months you were over there? Or can we say the whole thing sucked and we can process the whole thing, if you can see the air quotes that I'm not putting up because you're listening on audio? Or is that not part of this intervention strategy?
No, I'd say it definitely can be. Because, if we're working on a target memory, it's going to go in a lot of different directions because you're going to be thinking, it's going to be free association like we talked about earlier. Your left and right brain is going to be kind of like working together to kind of come up with these different things that you're going to talk about, and you tend to get off of the target memory a little bit and you kind of jump into a few different memories, and that's kind of where we jump back into, after a few passes, okay, now let's go back to this memory. How distressing is that to you now? And that's usually when you start to see it come down a little bit, like the subjective unit of disturbance. But usually by, packing, that one memory, you are in turn, attacking all these other memories as well. So I think that's definitely a really good analogy and definitely holds some weight.
It's cool. And I think it's encouraging because otherwise people will just become care averse if they think they have to unearth everything that they've ever gone through in life. You can roll it all together. It's much more efficient that way.
Yeah. And I will say too, this is like the one time, like I always tell people, like, this is the part of therapy that sucks. Like I know a lot of times people like to come to therapy, they look forward to it and they like to, get some stuff off their chest. And I usually tell them, like, this is the point where you're probably going to start no showing me a little bit. You might start canceling your sessions a little bit. This is the part that's not fun. And that's normal.
It's good that you pre-teach that. That's really cool that you pre-teach that. I'm going to start saying that more to my interns and my students too, because I think sometimes when we touch the more sensitive subjects and it gets away from symptom treatment to problem resolution, it gets scary, and they do tend to cancel or no show or reschedule. So I think pre-teaching that and mitigating some of that advanced thinking ahead, I don't want to go through the pain of seeing Brandon next week. You can tell them the previous week, say, hey, push through and come in anyway, right? This is where the real work begins. I really appreciate you saying that. That's probably going to end up being my takeaway, actually.
So Brandon, I know we like WTTA, we have like the list for like firearm knowledgeable clinicians. If I, as a person, wanted to come find an EMDR specific counselor, how do I do that?
That's a good question. I would say just calling different agencies in your area and just asking, do you have anybody on staff that is certified in EMDR? Whoever answers the phone at that agency will know what EMDR is. I would imagine. Psychology Today is another good resource if you're looking for counselors in your area. Usually they'll say what their specialties are, and if you see EMDR on there, that's a good one too. Also just going to different websites. There's usually biographies for different counselors that you can check on as well.
EMDR trained or EMDR certified is there are two different things, by the way. EMDR trained is the subset of people who are not fully through the certificate program. So after this basic course, I'll be trained. I won't be certified. But that is a kind of a clue or a key or a filter that firearms owners can reasonably rely on. If they see an EMDR trained person, they're probably not going to be judgmental about gun stuff because they understand trauma. And when you're working with trauma people, uh, it tends to be associated with violence, and you get a lot less judgmentalism with those types of folks. So if you're looking for a therapist and you can't quite discern whether or not they're going to be friendly to you as a gun owner, EMDR might be a good way to filter through that. Also, if they list veterans and law enforcement, pretty strong indicators that you're not going to be judged going into the agency.
Absolutely.
That's a pretty good show, guys. Should we wrap up here?
Yeah, I think so.
I think that was fantastic. Good job, Brandon. I appreciate
Thank
you
you.
bringing all
We're
the
just
knowledge here, man.
yeah.
Thank you.
Yeah, it was really good, and I appreciate you taking the time to prepare that presentation. It was a nice overview, and let's go around the horn real quick, and I can get off so I can go cough my brains out like I have been all morning and all week long, and you can stop listening to my AM radio voice. I'm about an octave lower today due to the cold that I have. takeaways. I'll just start. My takeaway is that I'm going to go talk to my interns and students in supervision over the course of the next week or so, and tell them to pre-teach our patients that they can expect difficult times ahead, and when those times come, if we're savvy enough to sniff it out and realize it was kind of a hard session, they may not want to come back, to invite them back anyway, because that's exactly what they hired us to do. So that's my takeaway. Eddie, what's your takeaway?
My takeaway is I've been interested in EMDR for a while. I heard about it in grad school, but it was like this weird light sound thing that never made sense. So I appreciate Brandon you doing this. And as we were going over it, I already texted my clinical supervisor asking about, hey, so let's learn more. How can I learn more about this, and how do I get into a training?
Listen, Kevin, what's your takeaway?
I think it's just nice to get the background information about these terms that a lot of the common person probably isn't familiar with. I knew it could help with traumatic events and kind of healing through that, but the training that goes into it and the actual process is nice to have more of a background and understanding of.
PB?
Yeah, I appreciate working with EMDR clinicians. It's not an area of focus for me, but understanding its tenets, understanding how EMDR clinicians are working with their clients, has been so integral to the work that I do, because so many of my clients have gone through that and are looking for that. So being able to work in a team aspect and say, oh yeah, this person's really good. You will benefit from this, and then you can bring that back to session, because they are different animals, the EMDR side of thing and the psychotherapy side of things. And so I would say it's not my bag in terms of practice. It's absolutely something that I really appreciate, and I like being able to connect with clients who have gone that direction.
Mike, what's your takeaway?
Every one of these shows is just another reminder that guns and mental health is not mutually exclusive. And when I hear this type of stuff, I think about, and I know I'm preaching the choir, because this is our mission, right? To incorporate the two and make it so it's just normal in the gun community. But, listening to Brandon, it's just like, I think about all the courses I've sat through, the CCW courses or just training courses. And it's like, they always invite a lawyer in to talk about defensive shooting. Right. And I think we got to get to this point where we invite a mental health clinician in to maybe give a 15, 20-minute thing about like what is available as gun owners, just learning about like this particular lane. Right. It's like, I didn't know that existed until today. So, I think this would be a great thing. I think we just got to continue to hammer home with the firearms trainers, especially like, hey, you always bring in a lawyer to talk about defensive shootings and like what's going to happen. Maybe bring in a local mental health clinician as well to let your students know what is available and what kind of things are out there. If that situation ever occurs, right? So I think this is an awesome show. I just appreciate all of you guys doing this.
That's a great point, Mike. And I think I want to make the pitch that Mike and Rob and I did a trauma mitigation video. It's about 7 or 8 minutes long. It's not very long. Maybe we can push that out to the trainers to just incorporate that. If they don't have a clinician in their community, they can at least show the video and say, hey, here's what you can anticipate. So that if you get into a situation that's sketchy, maybe you don't even use your gun, you just deploy it to solve a problem or keep yourself safe. The after effects are something to be expected. Maybe we should start distributing that a little more widely. Brandon, wrap us up. You did a great job, but tell us your takeaway and take us home.
Thank you. Yeah, no, I appreciate the opportunity to share about it. It's something I'm really passionate about. I'd say my takeaway is that your brain is an extremely powerful organ. I tell people a lot, if your brain can get yourself into a situation, it can also get yourself out. So I would say just, thinking about how if you go through something traumatic and you don't want to unpack it, it's going to be impacting your life one way or the other. So you have a choice to let it impact your relationships, let it impact your work, let it impact your life in some way, or you can rip the Band-Aid off, go through it in therapy and then, have the rest of those areas of your life healed. So I would say that's just a really powerful choice that you have to make.
Thanks, guys. It's been really good. And despite the technical glitches and my own illness and oversleeping and starting at 40 minutes late, I really appreciate you all and thanks for your patience. And if you're listening to us and you enjoyed this, please share it around. Don't keep this to yourself. Make sure that you let other people know and invite them in as well. So, on behalf of our platinum sponsors, the names of which you've heard throughout the show during our drop in ads, and on behalf of our entire Walk the Talk America family, especially all the people you've heard today, we wish you all great mental wellness. Take care.